Okay, so are we, I guess we're on then. Hello, everybody. Good evening, good evening, good evening. I'm Ebony Boulware. I'm the Chief Academic Officer for Advocate Health and the Dean of the Wake Forest University School of Medicine. And I want to welcome you here to celebrate Research 2026. I'm so delighted to be here at Advocate Christ Medical Center and to welcome everybody here as well as those who are joining us virtually. Throughout April, as you have seen, we are really celebrating research across our enterprise. All of the outstanding research that's going on, the many partnerships, the innovations, and the breakthroughs that we're making as an enterprise, given the research that we're doing. This is such an important celebration for us because one of the things that really distinguishes us is that excellence that we bring to our care every day. And that comes from the innovation and the thirst to do that better thing. And a lot of that innovation and those discoveries that come from that come through research. I can say I've spent most of my own career as a researcher, and through that work, I've really been excited about how research brings to clinical care that inquiry, how to do that address that problem and do that next thing, the next best thing, the better thing that's going to advance and help us all. And that's really the promise of research and what's so wonderful about it. Now, what's amazing about us is that we are a learning health system, an enterprise that really values what discovery and innovation bring to the lives of the individuals that we care for every day. And so that's why it's so important for us to come together as an enterprise and celebrate research and celebrate innovation. So today we're going to be, and throughout the month we've been highlighting multiple different areas through virtual and in-person events. And first, before I even get into introducing today, I want to thank all that have been involved in putting this together. It takes quite a bit of work for us to do this, and I know that the teams work hard to put together outstanding programs, and just so delighted and grateful to everybody who's contributed. Today we're going to talk about maternal and child health, one of the absolute most important areas for us to be talking about because it's where life begins, and really celebrating our lives from birth, early childhood, and all of those experiences that are so important. We know that when we improve the health of mothers and babies, we're really strengthening families and we're strengthening our entire community. So the work that we do in this area is so critically important. And we know there are such needs across maternal and child health that often are not addressed. And so this area is so important to how we think about how we'll be improving healthcare in the future. Today we're going to be talking about a number of different types of innovations and interventions, and I'm looking forward to the panel to really share that. One thing I want to say is that collaboration is really key to this work. It requires scientists, clinicians, nurses, healthcare providers, families who are willing, and our community members who are willing to come together to really address these issues. And so we're really grateful to all who participate, both within our system and in our communities, to do this incredible work. I want to thank the Center for Child and Family Research and all the investigators for contributing to tonight's program. Your work really reflects the spirit of Celebrate Research. Yeah, go. I'm with you. So I'm really delighted to see the program, and thank you so much. So now I'm going to introduce Dr. Amit Acharya, who's president of the Advocate Aurora Research Institute and Vice Chief Academic Officer, and Vice Dean for Regional Research Strategy and Integration at the Wake Forest University School of Medicine. Dr. Acharya is also Professor of Public Health Sciences, and he's a recognized leader in biomedical informatics and translational research. So come on up, Dr. Acharya. Thank you.
Good evening, everybody. Dr. Boulware, thank you so much, and welcome to Christ Medical. I'm going to keep my remarks short, but kind of highlight what Dr. Boulware alluded to, the work that is happening here, especially kind of in the area of pediatric and maternal health, is so important. And not only as a researcher and a clinician, but also as a father of two girls, I know they're in safe hands here, in the Chicago area. I'm a resident of Chicago. It gives me pride in all of the work that you all are driving. And not that I want to bring them in for anything else other than preventive, but still that puts all parents at kind of a calming state of mind. And it's because of research. We are an academic learning health system. The role that the school is playing now, we are all excited. And I know I was talking to a few of our colleagues from Winston-Salem, and their interaction and what they're picking up is there's so much of excitement among our clinicians and our researchers and our teammates, and it's only a matter of time that we can kind of continue to demonstrate at a very large scale in terms of all of the various research that's going on. So clearly, this is a special day where we are gathering here to celebrate you all. Our donors, our community partners, and our clinicians, our teammates, our nurses. It's a phenomenal team, and the work that's happening across our enterprise is phenomenal. And really, probably for the first time around in a long time, I'm seeing research and academics sitting front and center as part of a large health system, and that's exciting for all of us. So with no further delay, I want to kind of introduce Dr. Cheryl Lefevre, who's the director of our Child and Family Research. There's a phenomenal panel here, and I was just trying to get a picture with all of them so that each one of them have a grant, and then I'm like, maybe I could get a grant too if I get a picture. But I'll let Cheryl talk more about the team. But Cheryl, welcome. Thank you.
Thank you, Dr. Boulware, Dr. Acharya. There we go. Good evening. Welcome to Celebrate Research, Maternal and Pediatric Health, Shaping Tomorrow's Care. Thank you for being here and for your shared commitment to advancing research that directly informs how we care for our mothers, our children, our families within our communities. For those of you who do not know me, I'm Cheryl Lefevre, Director at our Center for Child and Family Research, and also Assistant Professor in the Department of Pediatrics at Wake Forest University School of Medicine. I'm a nurse by background and have been in research leadership position here at Advocate Aurora, for the past 20 years, and the last 13 years have had the pleasure of serving as the director of our Center for Child and Family Research. Through our center, we support both industry-sponsored clinical trials and extramurally funded investigator-led studies in pediatrics and maternal health. We provide research administration and coordination by an experienced team led by a very senior and experienced manager of clinical trials and a team of experienced and certified clinical research coordinators, many who are here tonight. I'm very grateful for your support. Our program tonight, though, is going to showcase the work our center's been doing to enhance the collaboration between scientists within Advocate Aurora Research Institute and our clinician investigators. Just as both Dr. Boulware and Dr. Acharya highlighted, we have really been hard at work. For the last year and a half particularly, we have been deliberate in our efforts to match scientists and our epidemiologists with clinicians to build upon each other's work product and extend scholarly outcomes. Starting in 2025, our center piloted a new program appointing 4 select clinical investigators with research time and dedicated research support to enable them to build their own extramurally funded research programs. In partnership with administrative support from Dr. Frank Belmonte within the Children's Hospital and Dr. Ann Windsor from the Women's Health Service Line, we implemented a bold idea to create a collaborative and shared partnership between our research institute and our clinical health system. Thinking boldly together as collaborative academic and clinical teams is central to our ability to contribute to Advocate Health as an academic learning health system. An academic learning health system is one that is designed to continuously learn from routine clinical care, apply that knowledge back into practice, and disseminate what we learn so that improvements extend beyond any site or system. A defining feature, and one that we're going to highlight tonight, is the alignment of scientific goals with our health system priorities. One effective strategy we've used is by creating the infrastructure supported by both internal investment and external funding for our scientists to work alongside our clinical investigators and their teams, building sustained relationships and really focusing on their scientific expertise so that we can solve real health system problems. The academic learning health system places strong emphasis on population health and social determinants of health, as do our scientists. Advocate Health recognizes that clinical outcomes cannot be separated from the social and structural context in which families live. This is very important for our maternal and pediatric populations. Those populations are inherently vulnerable, not only because of biological factors, but because healthcare experiences during these key life stages have lasting implications. Factors such as access to care, insurance coverage, transportation, trust in the healthcare system, and prior healthcare experiences shape engagement long before a clinician enters the room. Interactions during the prenatal period, delivery, postpartum care, and early childhood can really shape a family's long-term perceptions of the healthcare system and influence whether, when, and how they seek care in the future. Research demonstrates that interconnectedness of maternal and child health. Prenatal engagement is associated with later adherence to pediatric preventive visits, and fragmented or inadequate care early in life can serve as an early marker of risk for missed opportunities. Research can guide our health system interventions, from improving clinical decision-making to reduce unnecessary downstream testing and stress for families, to redesigning care processes in ways that strengthen trust, continuity, and engagement. This evening's panel brings together these concepts and brings them to life through applied research that is embedded in clinical practice and driven by our health system priorities. You will hear from three investigators whose work illustrates how rigorous science, grounded in real-world care, can shape tomorrow's maternal and pediatric health outcomes. To begin our panel, we'll hear from Dr. Rachel Harrison, an attending physician in maternal fetal medicine at Advocate Children's Hospital and associate professor in the Department of Obstetrics and Gynecology at Wake Forest University School of Medicine. Next, we'll hear from Dr. Melanie Marsh, a pediatric hospitalist at Advocate Children's Hospital and assistant professor in the Department of Pediatric at Wake Forest University School of Medicine. And then we'll hear from Dr. Veronica Fitzpatrick, a research scientist at Advocate Aurora Research Institute and associate professor in the Department of Implementation Science at Wake Forest University School of Medicine. Together, these presentations reflect the full spectrum of research impact, from prenatal care to inpatient pediatric practice to the design of primary care systems that better meet families where they are. They demonstrate how learning generated through routine care can be leveraged to reduce variation, address barriers, and improve outcomes for some of our most vulnerable patients. Following the panel presentations, we'll have time for Q&A. So I encourage you to engage with our speakers using the note cards and pencils you received on your way in. If you want to write any questions, just raise your hand up. We'll collect those cards and ask them during Q&A. And with that, it's my pleasure to introduce our first speaker, Dr. Rachel Harrison.
Okay, can you hear me? Okay, thank you. So I'm Rachel Harrison. I'm maternal fetal medicine, which for those of you who aren't familiar means I take care of very high-risk pregnant women. And before I get going, I do want to say thank you so much to Cheryl and the Advocate Aurora Research Institute and Wake Forest for everything you all have done to help me with the projects I'll be discussing today. I think everything that everyone has said so far is very true, that we're on the right path and making big strides, so it's very exciting. So like I said, I am a high-risk pregnancy specialist, and I think the reason that I honestly became a maternal fetal medicine physician and why I'm so passionate about research is because it's very difficult to care for pregnant women. And partly it comes from not understanding the changes of pregnancy, not understanding how their health changes while they're pregnant, And what comes from that, as we've all seen in the news and in our medical journals, is this increased rate of maternal mortality. And I think a lot of that comes from not really understanding pregnancy and pregnant women. What we do know about maternal mortality is that it often does occur in women who have high-risk pregnancies, but it also occurs in situations where it potentially is preventable. And so that's one of my passions and why I do research, is to figure out what we can do better for these moms. And exactly what Cheryl said is that there is this trickle-down effect, that if moms don't get good pregnancy care, then they end up having babies that aren't healthy when they're born, have long-term complications, and the morbidity of prematurity is very significant. And so the first thing I wanted to touch on is just kind of a basic science lesson, woohoo. And basically, there are significant changes in the body as a woman becomes pregnant. Some of them are more obvious than others, but I think the important ones to touch on are the ones that tend to have the biggest impact on maternal health, maternal mortality, maternal morbidity. The first is touches on cardiovascular changes in pregnancy. And essentially what that means is that when you become pregnant, you actually have changes in your heart rate, and you have changes in the amount of volume in your body. It goes actually up by 50%. And so the heart is working much harder than it's ever had to work in its whole life. And we often say it's like running a marathon or a stress test like you do in a cath lab. It's a huge change to the body. Pregnant women are also more susceptible to complications where their oxygen, like diseases where oxygen deprivation can occur. So flu, COVID, it was very challenging to care for pregnant women because the body is trying to shift the woman's oxygen stores to the baby. And so they have reduced oxygen reserves. They have a harder time coping with severe disease. The same goes for hematologic changes that, again, kind of put the woman more at risk for infection or things like that and allow the baby to implant and the pregnancy to continue. And so basically what will happen with these changes is higher rates of prematurity for moms who have baseline conditions, renal disease, hypertension, diabetes, and then higher rates of maternal death as well, especially in women who have baseline health conditions. So the first project I'm touching on here has to do with preterm preeclampsia and fetal growth restriction. I chose to talk about this project in particular because it basically touches on the fact that a mom who comes into a situation who's sick is often going to have a baby that's sick. And I sought to kind of have a better understanding of one, what happens to these moms and babies when they have these two diagnoses together, and also how does that impact their outcomes long term, and then how do I counsel patients who have this diagnosis. So working at Christ, we have 2 or 3 patients admitted to the hospital pretty much at all times with preterm preeclampsia, which is preeclampsia specifically less than 34 weeks, and fetal growth restriction when the baby is measuring smaller than it should. And both of these are essentially signs of severe placental dysfunction. And we can kind of stratify how severe the placental dysfunction is based on a test that we do looking at the umbilical artery. This is all very technical and very specific to maternal fetal medicine, but just to kind of give people an idea of what we're doing. But we use the blood flow in the umbilical cord to get an idea of how the placenta functions. And so if the blood flow is struggling, then we start seeing signs of that actually, and it's a pulse wave Doppler that we do on ultrasound that tells us, okay, this placenta is not working very well. And it actually is one of the few interventions in obstetrics that's been shown to decrease the risk of stillbirth. And so the better understanding we have of how to use this test, especially in these high-risk women, the better. And so it helps us determine delivery timing as well, because the more severe the Dopplers, the more high risk for stillbirth, the more likely we are to deliver preterm. You can go to the next slide. Oh, I do the click, sorry. Click. Thanks, Cheryl. And so when we looked at the severity, we broke it up basically into people that had normal blood flow in the cord to people that showed signs of elevated resistance within the placenta. And then we looked at basically when there's an absence or reversal of flow during diastole of the baby's heartbeat. And basically what that means when there's an absent flow or reversal of flow is that the baby's heart is pumping so hard to get blood flow through the placenta has so much resistance, it's actually pushing blood flow back to the baby, or not letting it go forward, it's stagnant during diastole. And it should be forward all the time. And so when it becomes reversed or absent, those are the most severely affected pregnancies. And so I touched on some of the findings that we had, which is that there's higher rates of hypoglycemia, the respiratory distress syndrome, that p-value, should be 0.026. And they have longer NICU stays, and their birth weight is significantly lower. And so you can see all of those on the right, the effects of these abnormal Dopplers is very significant on these babies. And a NICU doctor or pediatrician will tell you the difference between an 800-gram baby and a 1,200-gram baby is very significant for long-term outcomes. And the other thing that comes along with this is that the rate of cesarean delivery is also much higher, and needing a classical cesarean, which is an incision that's up and down on the uterus, actually is a lot more morbid for mom, higher risk of hemorrhage, higher risk for future pregnancies. And so these risks all go up for mom and for baby when we have these diagnoses. And so essentially what we found is that we can kind of counsel women about what to expect and how severe this diagnosis is, and basically gave us a better understanding of what our population is doing in this specific area. Another important piece of preeclampsia, and why I kind of wanted to talk about this as well, is that women who have preeclampsia have a higher risk lifelong of developing cardiac disease. And so one of the newer tools that's been developed in EPIC and being instituted in the advocate system is this cardiac risk assessment. It's a very busy slide, but I think what's important to focus on is the top 4 boxes. Basically, what the purpose of this is that when a woman comes in for her first OB visit, we're going to look at basically if they meet criteria for this, if they become high risk for a cardiac event during pregnancy. And so basically what it's going to allow us to do is say who needs to be referred to cardiology or MFM, someone like me, to counsel them about their risk in pregnancy. And if there's anything abnormal, do they need to be referred for future testing, lifelong care? And so that's kind of the purpose of this tool. And so what we're studying is, first we're doing a retrospective study that we've actually just started the data analysis for, which is very exciting. And we're basically trying to figure out, have we been actually looking at these things for all of our pregnant women when they walk in the door? The vital signs, most of the time we're getting, all 4 that are listed there, the blood pressure, the heart rate, respiratory rate, oxygen saturation. Risk factors, generally, those are things that we also assess. Age, race, obesity, diabetes, hypertension, substance use. But other things like, are we routinely asking women if they have symptoms for cardiac disease? And I would say we are not. And that's what the study we're doing now is going to look at, is are we asking women if they have dyspnea or orthopnea? Are they having any chest pain? Are they having palpitations? And this tool exists basically to say, okay, if you meet certain criteria, then you need to be referred. And so some of it is clear. You know, you have a history of hypertension, diabetes, you're 45 years old, you probably need to see cardiology for screening and evaluation, but some are a little more subtle. And so we have around 6,000 patients that we found that we're going to do a retrospective analysis. And then the plan is, once we have that data, to apply for a grant to look at prospective, how we do once the tool is implemented. And so then it's going to give us an idea of the pre-test, post-test analysis. And this is just exciting because, like I mentioned, maternal mortality is going up in the United States, and 2 of the top causes are maternal cardiac disease and history of congenital heart disease. So this is something that's very exciting. Lastly, I don't have a slide, but we did find out recently that we got a grant for a pilot study looking at antibiotic prophylaxis for women who are undergoing a cerclage, and so that's exciting. That's another thing that we're going to start very soon, June 1st, so yay. Thank you.
Hi, good evening. I'm Dr. Melanie Marsh. I'm a pediatric hospitalist, primarily working at Lutheran in Park Ridge, and happen to be a Wake Forest residency graduate, so was really excited about our merger because I've had the opportunity to connect again with a lot of people that really inspired me to be a clinician in hospital medicine and also to be an academic researcher. So it's great to be able to make those connections and continue our collaborative research. I wanted to talk about a little bit of a personal difficult story to piggyback on some stuff that Dr. Harrison has shared, which is that unfortunately about 3 years ago, I lost my youngest son shortly after he was born. And I wanted to talk a little bit about this because Although the nurses were extremely kind around the time that, we knew that he was going to die, when the doctor came in to pronounce him dead, could not find a stethoscope, could not find a clock, and could not locate anything to be able to examine my son properly. And although I know that this is a very extreme example, this is something that I think about every single day, is those last moments that I had with my son. And it's so important when patients come into our hospital system that we communicate with them effectively, because everything that we do matters. And the way we say hello and the way we walk into the room is really important. And I wanted to highlight a little bit of work that we've done in this area. Dr. Butler, who's in the audience, has partnered with me recently on this work as well. I'm really proud of her efforts in this, particularly towards patients with complex medical needs and their families that report a lot of marginalization during their hospitalization. And we can see in multiple settings where we can take learners that are sort of underperforming compared to their peers and actually accelerate their growth in this region by training them in communication skills and also comfort and familiarity with these complex medical devices that children are increasingly having. And so we can actually shift or move the needle once we practice deliberate training in these areas, and families report increased satisfaction and just respect and trust in our healthcare system when we can communicate with them effectively. Doesn't even matter what we're communicating about. It can be just about the placement of an IV. But again, all that matters, because once patients come in our hospital system, they're counting on us and they're trusting on us to do the right thing. And this type of work has also been picked up by the National American Pediatric Program Directors through APPD Lesson. And we've launched a national curriculum in hospital medicine concepts and how to treat patients properly for inpatient care. And this is also being studied through the APPD Learn group that also picked up this study to look at how those outcomes are transforming patient adjacent care. So we're really excited about this and really proud of Dr. Butler and all of her efforts towards kids with special healthcare needs. I also wanted to talk about this, which is really important. I had a GI consult on one of my patients this weekend, and it was a very complex medical patient. And he went into the room and he asked the family, yes, we can do this study, but what are you going to do with the results of this study? And that's really important. We can do tests, of course we can do tests, and unfortunately the farther out we get in medical care, the more tests are available to us. But not all those tests are good, because once we find something, then we have to do something with it. And my work in UTI really focuses on that. You can see a picture here on the slide of what a voiding cystourethrogram looks like for kids. And when they are diagnosed with an abnormal ultrasound, they're committed for the 8AP guidelines to this voiding cystourethrogram, where they're strapped down to an operating room like table, catheter is inserted, and they're asked to pee in front of a group of many healthcare professionals. And now there are actually national groups reporting how this is akin to like sexual assault, essentially, and dissociation and fear of healthcare systems, not just for the patient, but of course also their family. And this is a test with radiation exposure as well. We did recent work through the LiveWell grant, and this partnered with our Wake Forest colleagues down in the Southeast. Also, Levine Children's Hospital was a study site for us. And among these 6 sites, we actually found that the early ultrasounds were more likely to have false positives. And so delaying the ultrasound just a tiny bit more actually led to better outcomes for the patient and less of these invasive downstream testing and potentially less prophylactic antibiotics as well. So again, it's not just about what tests we should do, but when we should do it and how that matters to the patient and their family, and helping them transcend, the healthcare system and understand how to get back to access for care. So this is a really important focus. I was very fortunate to just recently have been awarded the K-12 through the Wake Forest. Thank you. One of the things that our study team found as we were doing this prior work with UTI is that the ultrasound reports were sort of all over the place, and some radiologists were reporting this is SFU grade 1, and others said no, this is UTD 0, and then the next person said no, this is mild pelviectasis. Well, actually, it's kind of all saying the same thing, but it's using a lot of different language. And that's a real problem for us, because for someone like me or other hospitalists who are looking and trying to understand what to do next for the patient, it's very confusing. Like, is that abnormal? Should I refer the patient to a next step? Should I put them on prophylactic antibiotics? Do I refer them to your urologist? So just quantifying that variability in ultrasound interpretation will be extremely important to reducing this variability. Unfortunately, overdiagnosis or diagnostic uncertainty is a huge driver, as you would imagine, of overutilization in healthcare. And so to be able to get this right and all say the same thing, both accurately and using the same terminology and language throughout our enterprise, both here in the Midwest and also in the Southeast, will create a nice, actionable, pool of patients that we can then build clinical pathways around, and we can conduct prospective trials. And ultimately, of course, the most important thing is to reduce harm and improve the healthcare experience for the patient and their family. And then the second aim of this is to build on the first and understand why that variability exists. Is it at a patient level? Is it at a technician level? And try to really move the needle in creating a consensus reporting guidelines that can be implemented into the EHR, that can be really standardized across our enterprise, so that we can all be saying the same thing in the same way. And that's what really matters for patients and their families.
So I'm excited to go last. It has been a pleasure to work with Cheryl over the past 7 years that I've been an advocate, and certainly with Rachel, Dr. Harrison, and Dr. Marsh. So I'm taking a little bit of a different approach. I'm not a clinician, I'm a researcher by trade. And I sort of want to talk about a little bit of a different issue, which is really about utilization and getting people to the appointments that they're supposed to attend. I loved Melanie's talk about communication, because that is really critical to the work that I do. I sort of just want to level set this research a little bit. So I'm focusing specifically on early childhood well-child visits. So this is that 0 to 15-month well-child visits, where we know there's anywhere from, putting aside sick visits, there's usually about 7 to 12 within that time period. And again, that's not considering a child with medically complex issues. But there are certain things that we know contribute to not showing up to these appointments. There's very, very obvious things, like anyone who drove down 95th Street, Dr. Boulware, knows that transportation is a really, really big issue to get to these appointments. It takes a long time, it costs money, there's bus issues, there's car issues. We know that this is a problem, right? We also know that time off work is a really big issue. We know that a lot of these people are shift workers. This is a gig economy. We know that it's really hard to take time off. We know that that is going to have direct implications to people's pockets. Childcare is another big issue. Rarely do people just have one child. So this is now trying to compete with things like childcare, trying to figure out if your child can come to the appointment. You might not be able to get off in time for CPS to get out, by the time that you get to the appointment. We know all that. However, we also know, based on this graph right here, that there are certain demographics of people who are less likely to show up to these appointments as well. We know that lower income people are less likely to attend their appointments. We know that Black and Hispanic children are less likely to attend their appointments. And we're seeing, this graph is sort of illustrating that usually 1 to 2 months, most people will attend their appointments, and then you sort of see this divergence at about 2 months, and it never comes back together. So you stop attending your appointments at around 2 months, it sort of funnels like this, and then we just never see the same rate of attendance. So I was awarded a grant about 10 months ago to sort of dive a little bit deeper into why people don't attend these appointments. Again, we know some reasons why people don't attend, but there's a lot more to this story that we're really trying to figure out. So one of the things, and like Dr. Marsh had said, communication is a huge reason why people do not attend these appointments. We know that there's 2 clinics right over here, the outpatient clinic. They have a no-show rate of some of these clinics about 30 to 40%. That is huge, and that is different than late cancellations, that is different than cancellations. These are people that have scheduled appointments and they do not show up to these appointments. The administrative effects to these appointments or to not showing up to these appointments are huge, right? Like this ends up with really big scheduling issues. Patients delay, vaccinations. They end up not getting the screenings they need. There's a lot of implications for this. So part of this was sort of like, we know that 30 to 40% of people are not showing up, but the denominator in these are just not showing up to these appointments. We're not really figuring out like what is or who are actually driving these no-shows. So this study sort of looked at this qualitatively and quantitatively. One interesting thing that we actually just found out this week by looking at our data is that people who put as their primary language as Arabic or Spanish were 2 to 3 times more likely to not show up to their appointments. One really interesting thing about Advocate is we don't actually send appointment reminders in any language other than English. So, you know, when we think about these little things that maybe like the system could do to sort of offset some of these things, when we look at the fact that language might be a driver of non-attendance, maybe we have to go back to the drawing board and say like, well, what are we actually doing to support our patients? One of the other really interesting things about this was the communication between the clinic, the providers, the MAs, and the patients as well. So I think it's kind of just an assumption that when you're talking to a patient that they're going to understand what you're saying, and that turns out absolutely not to be the case. A really good example of this is that across the board, every single family that we interviewed did not understand what percentiles were. Every single time you go into a pediatric appointment, you get handed something in an after-visit summary that says that your child fits here in this little graph. Patients absolutely do not understand what they mean. They assume that they need to be at 100%. They think if they're not at 100% that something's going on with their baby, and this is also driving no-show rates because they don't want to go back to the doctor. So little things like this that are really hard to figure out just by looking at our quantitative data are things that we're trying to explore and trying to dive deeper in. The other big thing about this is patients fundamentally did not understand the difference between a well-child visit and a sick visit. They just think I show up, and they don't understand that a well-child visit might, screen, your ages and stages and all that stuff, which is very, very different than your sick appointments. So what are we doing about this? I do I will talk about this all the time. We try to create really, really low-cost, low-burden interventions. So what this is, what you're looking at, is almost every single one of my studies, my co-PI is a human-centered designer. And so what we do is we spend anywhere from a year to 2 years, probably anywhere from $50,000 to $150,000, and we dive very, very, very deeply into what is happening at these clinics. We talk to multiple families. We sit in waiting rooms for hours and time how long people sit there. We see how front desk interacts with the patients. We see how people flow through the clinic. We see how long MAs spend with their patients. We see how long physicians spend with their patients. And we take all of that information and we create really low-cost paper-based tools. The beauty of this is that it doesn't compete with anything else. It is really, really, really easy to integrate. It is low cost, it is low burden, and they work. We've done this in prenatal care. We are now moving it over to pediatric care. What you guys are looking at right here is our 6th prototype of a tool that we created. We are now into our 12th prototype of this same tool. We are actually tomorrow going, well, I'm not, I'm flying to Dallas at 8:45, but my colleagues are going to the clinic tomorrow to actually time the people in the clinic and filling it out to see if it actually fits in workflow. If it doesn't fit workflow, we will not bring it to the table. But I think the whole point of this research is that there's a multi-tiered approach that needs to happen, right? Like, we're not going to be able to drive everybody to their appointments. We're not going to be able to offer childcare all the time. We're not going to be able to call people's bosses and tell them to pay them even though they're not showing up. What we can do is we can maybe be a little bit more culturally sensitive and, do things like, I don't know, reminders in a different language. We can do these really low-cost, low-burden interventions, like just creating a tool to tell parents how important well-child visits are, and then we could figure out sort of the harder things a little bit later. But my whole point in this whole thing is that we really need a multi-tiered approach to getting people to show up to their appointments, because really, if they're not showing up, we can't really do anything, right? So, thank you. I guess these are my, I'll do the key takeaways since I'm up here, since I wrote 75% of them. So I think the key takeaways of Dr. Harrison's was that pregnancy changes every physiological system in the body, that high-risk pregnant persons and their neonates need to be closely monitored for acute and long-term outcomes. What may be a single patient encounter for a clinician can be a defining lifelong experience, and I want to thank Dr. Marsh so much for sharing that very deeply personal story. I think, as a provider and as a mom, I think, you get this very interesting sort of perspective of things, and I think what makes you such an interesting and wonderful provider is the fact that I think you care so deeply, and I think Advocate is very happy to have you as a provider. There's also a big thing with diagnostic inconsistency, which is great that you got your K and we can all figure that out. The other thing is that asking patients directly what barriers are instead of assuming that everything is one of the 7 social drivers of health issues is key. You know, this is where you learn about what people value. This is where you learn about confusion. This is where you learn about the communication issues that develop in these closed-door appointments. The other thing is there needs to be a tiered approach to appointment attendance. I know there's a lot of work on the Wake Forest side, especially in Joey Skelton's group, around maximizing appointment algorithms and getting people, in where other people wouldn't. There's also the interpersonal, the intrapersonal, that the scheduling part, and then the system overall. And I think there needs to be some sort of handoff between all of these things, to get patients in the door and to be treated well. So I think that might be it. Yeah. Okay, I'll turn it over to Cheryl.
So we have plenty of time for question and answer session. In case any of you did write down a question on a card, please raise your hand so we can collect them and bring them up. And I'll kick the questions off with the group. So congratulations and thank you so much for sharing your insights tonight, telling us a little bit about the work that you're doing. It's just really a small snapshot of what you have been bringing to your clinical practices. So the 3 of you have been part of our center's pilot program to build this connection between our scientists and our clinician investigators over the last couple of years. I was wondering if you could each speak to how that has impacted your research work and, if applicable, how you practice because of that work.
I don't practice, so it's up to you too.
I'll start. I've been so incredibly grateful for this opportunity to partner with our research scientists, because I think that makes all these projects so much more robust and so much stronger. Really having an epidemiologist on my team has really helped me understand a lot better, not just asking the right clinical questions, but how do we build a really powerful study to think about achieving the outcomes that we want to achieve. And so having the partnership with our Center for Family Research has been incredibly helpful, just to learn about the work that others are doing and the ways that we can collaborate. Unfortunately in pediatrics, we often operate in our individual silos and we don't realize, how much work is being done in similar fields. And so having partnership with other physicians in the outpatient and inpatient world, and also having connections with maternal health, I think has made our studies so much more powerful and robust to look at the full spectrum of care for the patients and their whole family system as they're entering our healthcare system. And I hope that allows us to continue to effectively move the needle across our academic learning health system.
Thanks, Melanie.
Thanks.
Rachel, did you want to?
Yeah, I think to kind of piggyback on what you said, I think having that group to just bounce ideas off of has been really nice. And even if the person, often Veronica is this person I feel like for me, where she may not be directly involved in the project, but she'll say, hey, I think you should pursue this, or this is more of a doable project, or something along that lines. And I think from my personal experience, the best kind of output that I've gotten as part of these kind of joint connections is working on grants, because that's something that I'm very new to. And so being able to have that very hands-on feedback from people who are more experienced than I am and have been awarded multiple grants, and hearing their thoughts and feedback for me was very helpful. And I feel like I've learned a lot in that last year, couple of years I should say, working on the grants that we've applied for together. And it's also just fun to be around people who are passionate about research and women's health, and working hard to do great things. So I've appreciated that a lot.
Yeah. I know, Veronica, you said, well, you don't practice, so the question was for Melanie and Rachel, but I want to also give kudos, because you were really an inspiration and came to me, and we partnered to kind of developed this idea of creating our academic councils, making really, taking those specific steps to bring these groups together. So how has that impacted your work and your ability to be successful with your research?
Thank you for the question, Cheryl. I work in a health system because it is the most directly applicable way of implementing evidence-based research. I think, and given this learning health system model, I think it really is like a very good environment for taking sort of epidemiological findings based on our own EHR and our own patient population, and being able to partner with people like Dr. Marsh and Dr. Harrison and say like, hey, based on this, I think we could do this a little bit differently. And I think through CCFR, and I think through grant writing, and I think through just like, co-authorship on papers and just all that, expertise and meetings, we've developed a relationship and a trust with each other to where we're not, the number one thing that we all care about is just giving the best care to patients, right? And that is always changing, and that is, and to do that really has to be some sort of marriage between patient care and staying up on research. And I think, like I said, that is the learning health system model. And I think through CCFR, and I think through just, the relationships that we've developed throughout the years, there really is like a push and pull between all of us with being able to do that and then test it. If it works, let's keep doing it. If it doesn't, let's not. Research is takes a very long time, and it's messy, and it doesn't always work. It often doesn't work, and and I think that we've been afforded the ability to to collaborate in that respect, and I think it's been really beneficial to us as researchers, as clinicians, and to our patients.
Yeah. And I definitely can see the growth that has happened in all of you individually, but the program collectively, as well as we've been doing this work and really being, intentional to bring key players together. So thanks for that. Here's a more abstract type of question. If you could redesign healthcare, how would you think about do a better job of connecting prenatal care with that postpartum, postnatal care period, and pediatric care? Thoughts?
I love this question for so many reasons. But I actually was rounding on a postpartum patient. Was this yesterday? I had a long day yesterday. It was yesterday. And the husband was supporting his wife who was pumping, and they were talking about their baby was in the NICU and how difficult it was for her to be receiving her medications for her blood pressure and pumping and be there for vitals checks and all the things that they do for postpartum moms, but also to be able to go down to the NICU to see the baby. And he's like, it would be great if the mom's like postpartum bed could be right next to the NICU bed. And I was like, I don't know if anyone does that anywhere in the country. Like, I've never heard of such a thing, right? there's always separate floors, and in our hospital they're fairly close because they're both in the East Tower, but there's still an elevator ride and a 5 to 10 minute, depending on how far away you are in the wheelchair. So I thought that was something that was very interesting. But I think, actually, go ahead, Melanie.
Yeah, no, I mean, I would actually like to piggyback off of that, because unfortunately, everyone's really excited when they bring their baby home, and then, the baby gets a fever, within the first week because they have an older sibling in, daycare, and the older sibling brought home some, unmentionable germs, and then now, unfortunately, this poor baby, the parents just got home, sort of sleeping, probably not. And now they're back in the healthcare system almost immediately, and that mom is still really in the immediate kind of postpartum period, and how, trying to figure out how we can support her. I mean, just this past week, we had a mom who I could just tell, like, she was trying to hand us the baby, but she had shared with us she had a 3rd-degree tear. So we're like, please don't move, we'll come to you. But, she's just trying to get comfortable, and these hospital rooms are, very uncomfortable. For postpartum moms, especially in the first couple of weeks of recovery, depending on what their type of delivery is. And I think we really do. We try to support them with lactation support and pumping materials. But I do think that's a really important niche that we need to continue to partner on, is how we can support, families that either have extended stays in the hospital or patients that go home and then come back for jaundice or febrile illness or respiratory illness within the first couple weeks of life, because that mom is really still a patient too. And then the poor partner, whoever they may be, is also still struggling because they're trying to leave the hospital, go take care of the other kids that are potentially at home and coming back and forth and trying to support. So again, not just thinking about the patient that's right there in front of you, but the whole family system that's interacting with that patient, because in pediatrics especially, it's not just about the kid, it's about the whole system in which they're living in. And so being able to operate appropriately and take care of the whole family is really important, I think, to optimizing care and hopefully getting them expediently back to where they belong in their own homes.
Mm-hmm. Excellent. Veronica, did you have?
I have a lot of opinions about this. No, I actually completely agree with Melanie. I think, just in my own research, it just feels like, prenatal care and then pediatrics and then primary care all sit in different places in our system, right? And ultimately, they shouldn't, and I do think that focusing on the mom, or focusing on, and I mean mom broadly, like whoever that primary caregiver is in a family, is critical. And if a mom is unhealthy in a family, the health of the entire family is sort of sacrificed. And I remember very early into this pediatric well-child visit study, we just ask questions. We're just like, hey, what do you do here? What do you do there? And there's been a really big push to screen women for depression, postpartum women for depression in pediatrics. And so we're like, oh, okay, tell us about that. And they're like, yeah, we go to Edinburgh to the woman. We're like, great. Okay, so what do you do if it's her score is really high? And they're like, oh yeah, we just refer her out. I'm like, refer her to where? And I'm like, what do you do with the actual test? You don't have her in the chart, so do you put it in the baby's chart? What do you do with it? And they're like, oh, well, we'll send them over to the case manager, but they only work on Tuesdays. I'm like, oh, okay, but well, what happens? They're like, well, if it's really bad, we'll send them to the hospital. I'm like, but they just had a baby. What do you do? And it's just things like that, where it's I just don't think we're asking the right questions a lot of the time, and I think the mom gets lost in the shuffle a lot. And the mom is really the one who's, struggling a lot, because you have a family that's changing. You're going through those physiological changes, as Rachel was talking about, and there's and you're dealing with trying to figure out how to breastfeed and trying to figure out with other kids and trying to potentially deal with PPD or PPA, and you're supposed to, ACOG recommends handing off to primary care, and there's just so many things working against the health of a family in those early stages. Even in the best of cases, it's really, really, really challenging. And I think that because we have these systems that more or less operate on different sort of service lines, that the lack of integration in these three sort of, very clearly delineated groups is ends up sort of leaving the mom behind. And I think if we're going to do anything to change the outcomes of children, we need to be focusing on the health of the mom. And a lot of that starts with making sure that they're not being lost in our system, and making sure that we're, sort of sweeping them up and making sure that they're either in mental health care or primary care, or even seeing their OB in specific circumstances. But I think you would ask any mom on the planet if they would sacrifice their own health for the health of their baby, and every single mom would probably say, probably not my mom, but most moms would say, rest her soul, but most moms would probably say, yes, of course, I will take my kid to the doctor before I would take myself to the doctor. And ultimately the long-term consequences of that are very negative. And I think we need to do a better job of supporting moms to be able to support their families.
Honestly, just even walking into a room and saying, hi, how are you? I know that seems very straightforward, but unfortunately, there's so many times we're rushing and we're trying to get the presentation out, and this is a 13 patient presented with, everyone just forgets to walk in and say, hey, how's it going? How are you doing? Here's who we are. And just really taking the time to just focus on asking the right questions, not the ones we think should be asked, but the ones that actually need to be asked, I think.
Yeah, excellent. So proud that you guys work in this system and take care of our patients, because you really are so passionate about the work that you do. I want to be respectful of everyone's time this evening. I want to thank all of you for coming this evening. Thank you to all of our speakers. You guys are amazing. I feel so honored to be able to work with you every day and be able to really advocate for you and for the work that you want to do. It is really an honor, actually, to moderate this session tonight. So thank you for your great work.
Cheryl, I echo your sentiments, and congratulations to the panel, all of the amazing work that's going on. I want to take a brief moment to thank you all for being here. Dr. Boulware making the trip here to Chicago, and we have several leadership from our academic cabinet. Dr. R, Dr. Lynn Maganak, Dr. Ferdui, Dr. Darcy Reed is here, and Dr. Greg Hawkins is here. So thank you again. And for the planning committee, I think you have worked tirelessly, and this whole month, although the activities are happening now, the team has been kind of meeting. I also want to kind of, both the co-directors of the planning committee are here, Dr. Waganak and Dr. Ferdui. Thank you both so much. And I know Mercedes and Lori and Ari, and there's so many people behind the scene for making this a huge success. And end of the day, it is celebrating the work that you all are doing and our teams, and for our patients, and it's such a proud moment. I think there's something magical happening here, Cheryl. Continue that work, and I was telling Dr. Boulware that with everything that's happening across the system, and Wake bringing in all of the intellectual capacity and the support and the structure that we're working on. Yesterday in the cabinet meeting, Dr. Boulware spoke about these small little innovations that we need to focus on, and that's coming from our practicing physicians. They're seeing a problem on the ground, and they're trying to solve for it, and really kind of that combination of scientists and clinicians coming together and asking those important questions, which there are stakeholders right then and there that we can kind of take it back. So it's exciting. Again, there is a reception back here. Please feel free to kind of stay and talk to our leadership team here. There's food, there's drinks, and again, thank you all for the important work. And to everybody online, thank you for connecting. I know traffic in Chicago is like crazy, and I know a lot of you wanted to probably be here, but I'm glad that you all are able to join. Thanks again. Have a great evening.